Welcome to the Learning and Development Forum. My name is Heng. I am the chairperson of the Special Interest Group for Paediatric Palliative Care and Asia Pacific Hospice Network. So this is a forum that we have actually conceived, or actually my Malaysian colleagues have conceived, to have us meet once every 2 months to share some of the things that we do day to day, share some of the findings we obtain through various pieces of research. And in this particular instance, we have a colleague in New Zealand sharing with us some of the findings from her study, which is, she will tell you, part of a PhD thesis around the topic of resilience. So this is something which is very close to my heart. I've been sort of thinking about this for a very long time because I run a team looking after sick children, and we all agree, and majority of us are looking after whether sick children or sick adults. We need to kind of find ways to ensure that we can sustain ourselves doing this work. And oftentimes when the going gets tough, some of us actually either, become very, very tired, or we burn out, or we unfortunately leave the practice, which is very, very sad. So there have been works by various people in the domain of resilience, thinking about how this can help sustain some of us in the practice that we do. And I'm so glad to be able to have a friend from New Zealand, a new friend that I met this year, to come share with us some of her work. So Gemma is a nurse specialist in pediatric palliative care at Starship Child Health in Auckland, New Zealand. Gemma also holds an academic appointment in the School of Nursing at the University of Auckland. And she has a background in children's oncology nursing and undergrad nursing education. She has recently completed her PhD in nursing, exploring the experiences of staff working in children's blood and cancer centers in New Zealand, with a particular focus on how staff maintain resilience in their work. This presentation will explore the findings of Gemma's doctoral research. The title of this talk is "We Are All a Family: Resilience of Staff Working in Children's Blood and Cancer Centers in Aotearoa." Pardon me.
Well done, said perfectly.
Thank you, which actually also means New Zealand. Thank you, Gemma, over to you.
Thanks, Heng, and thank you, Heng and the team, for the opportunity to present to you today. I will just share screen and hopefully you'll be able to see my presentation. Is that working okay?
Yes.
Yes.
What have we frozen?
Very good.
Can you hear me?
Yes, I can.
Yes, excellent.
You're good to go, you're back.
So thanks for that lovely introduction, Heng. As Heng said, this presentation is based upon the findings of my doctoral research, which was finished. Oh, yeah, I'm back. Okay, cool. Thanks, Heng. So as Heng said, this presentation is based upon the findings of my doctoral research, which I finished at the end of last year, and explored staff experiences of working in a children's blood and cancer centre in Aotearoa, which is the Māori name for New Zealand. Before I start into the presentation, I do want to acknowledge the organisations that funded this study. So this was very generously funded by the Cancer Research Trust of New Zealand and also the Starship Foundation through the Heather Force Nursing Scholarship. And while the study was done in children's blood and cancer centres, I want to acknowledge that the findings have relevance in lots of different other settings. And I'm certainly aware of the findings being applied and used in other settings around New Zealand in primary care and in tertiary education. So I do hope that today there will be something for you all to take away from this talk. I thought I would start by talking about the context in New Zealand that the study was done and how I came to research in this area, a little bit about the literature and how we approach staff wellbeing and resilience before 2021. I want to challenge you to rethink how we've previously approached staff wellbeing and resilience. Then I'm going to talk a little bit about the findings of my study and the theory that was developed out of this study as to how staff maintain resilience working in this area, and talk a bit about the practical application of the theory, and hopefully some take-home messages, with some time at the end for some discussion and questions, hopefully. So Aotearoa, or New Zealand. So we're a small country, albeit a very beautiful country, lots of beaches and lovely places to visit. We have a population of 5 million, and at the moment our Prime Minister is referring to us as the team of 5 million as we approach navigating COVID and being back in lockdown. And I think that really reflects New Zealand's culture of being a country that values kindness, tolerance, is open-minded and welcoming. And I think while we don't always get it right, we strive to be inclusive of all cultures and differences. Largely we're described as being a relaxed country, very positive, we work hard, and family and friends, otherwise known in New Zealand with the Māori term whānau, are really important to New Zealanders. I think that's important to acknowledge in going through this study and the theory that was developed. Family is of critical importance to who we are as Kiwis. We are a bicultural nation. We have our Indigenous population of Māori, and Māori values should take equal importance to those of Pākehā New Zealanders. And I think that's something we're still working towards as a country, but as our goal. So my journey as a children's oncology and palliative care nurse really began as a new graduate nurse working in the Starship Blood and Cancer Centre here in Auckland as a staff nurse. And when I started, there were lots of really experienced nurses that had been there a long time. Being a new graduate in this area was something that was relatively new. And I was really fortunate to have this group of supportive, nurturing, caring, encouraging senior nurses around me. There was this amazing sense of camaraderie, and long-lasting friendships were created that still continue with me many years later. While we experienced really tough stuff in our work, as all of you will be familiar with, we also had a lot of fun. But over time, the unit changed and some of those more senior nurses left and were replaced by more junior staff that didn't have that same level of experience. And I think that's a natural course of any unit. Things change, people change, go off and do new jobs. But it really made me think at the time, you know, there's some staff that stay here for their entire careers and many, many years, and others that come just for a short time and leave. And when starting my PhD, I was really keen to kind of learn more about that and learn a bit more about what kept staff working in the area. Why could staff continue to work there? At the beginning, I was very aware of the plethora of literature out there that talks about stress and burnout. And I was clear that I didn't want to take that path because that wasn't my own experience. And so I really wanted to understand this from a resilience perspective, because we know it's not all bad, particularly if the only photo you can find of yourself at work is dressed as an elf. So these were from, we used to every Friday in December have Christmas dress up days. And I really want you to think about your elf moment, you know, a moment in your work recently that has been enjoyable and has been fun and something rewarding that's part of your role. And hold on to that now as we journey through what the literature says about working in areas like children's oncology. So children's oncology, not surprisingly, has been described as an emotionally taxing environment. And I think this is certainly literature that's shared with children's palliative care, caring for adults with serious illness, and in many other specialties in healthcare. We know that there's been a significant body of research done about the impact of caring for adults and children with serious illness. It has largely looked at medical and nursing staff and has been strongly focused on stress, the high rates of burnout, the negative psychosocial and medical outcomes that come with working in these areas. There's been very little literature that looks at our colleagues in allied health roles, and support staff roles, and cleaning roles, and very few studies that actually look across the board at the whole team. So most studies look at individual professions, and most take a very biomedical perspective in how they have explored experiences or psychosocial wellbeing. There was one study before I did my study that looked at coping and resilience factors in a small group of nurses in Australia by Melissa Zander and her colleagues back in 2013.
Hey, Gemma, you need to unmute.
Oh, I'm back.
You're back. I think your last word was 2015.
2013, but thanks.
13. All right.
So this study described that nursing alone has stresses, but paediatric oncology, and I'll add in there other specialties as well, as I don't think this is unique to paediatric oncology, adds another layer. And they identified that there were 5 things that contributed to nurses' resilience: spirituality and religion, insight and self-awareness, having a supportive clinical team, good social supports both at work and outside of work, and the ability to reflect and problem solve. And you'll see I've highlighted a supportive clinical team and social supports there, because these are 2 things that came through strongly in my study as well. This study, though, also highlighted the need to further understand and clarify what resilience actually meant. And so at the beginning of my PhD, I undertook to further understand how resilience had been conceptualised and defined in empirical literature from 2000 to 2015. And really what's this paper, which you can go and have a look at and read if you're interested in learning more, but what this paper led me to understand is that there was no universal way of defining, conceptualising or quantifying resilience. And that paper looked at resilience in lots of different settings, not just healthcare. It was across the board. So there were papers from the military, from family resilience, education setting, adolescents, oncology patients themselves, a huge range of different settings. Most looked at individual professions or individual groups. Again, the lack of that consideration of the social group, and came from a biomedical framework. I then went on to try and understand how resilience fitted in to our lives as health professionals by writing a reflective account of my own experiences, linked to these, linked to the paper around how resilience had been understood in empirical literature. And that was a really interesting experience and quite challenging, reflecting on your own personal journey. But really what I learned from both these papers was that resilience is a social construct. It's something that's different for all of us and different from moment to moment. It's not something that we can easily describe or define. It's something dynamic, it's contextual, and it's really dependent on the situation that we're in and the environment that we're surrounded by, being the physical environment, but also the people that are around us. So in reflecting upon how up until now we've viewed resilience and staff wellbeing, I think we've had this strong focus, certainly in New Zealand, and it may be different in other countries, on autonomy and focusing on the individual and trying to strengthen individuals. When it comes to staff wellbeing, we talk lots about encouraging staff to exercise, to eat well, to practice mindfulness, and all those things are important. But I think it's important to consider the bigger picture as well, and to consider the social context that individual lives within. So often we see comments like these you can see here and read about. So we need to teach nurses about stress and coping. It's imperative that nurses find ways to prevent burnout and effectively manage compassion fatigue. And really statements like this, or focusing solely on the individual, can actually lead to a sense of failure and victim blaming. And it's not something that we can necessarily learn on our own as an individual. So I want to challenge rethinking that approach and rethinking how we understand resilience, and start to appreciate that as individuals, we never ever come alone. We come with our own experiences, our own relationships, our own family, friends and whānau that support us and encourage us. And we're never alone at work either. We have our colleagues around us, a team around us that support us in our work and in caring for our patients, and an environment being the health system that we work in, sometimes for the better and sometimes for the worse. We also have the families that we care for and the physical buildings and environment that we work in. And they're all things that influence us as people and how we react and respond in times of crisis. So I think if we take a social approach, we can then begin to really consider some of the values and principles that are strengthened together to enhance both the individuals within a team, but also team resilience. And so concepts like secure attachment, but also critical values like trust and belief and permission to fail, recognizing that we're all human beings, that we're not all pillars of strength all the time, and that sometimes we are going to struggle and need an extra level of support around us. And I think if we take this approach, then hopefully we give everybody the opportunity to flourish and thrive and to reach their full potential. This paper, Connecting Theory with Practice, was written as part of my thesis, and you can have a read of it, but it really looks at the dichotomy between taking an individual approach and a social approach to understanding resilience and health professional wellbeing, and the benefits that the social approach can have for individual clinicians, but also for health professional teams. So if you're interested, you can have a read and understand a bit more about that. So the Aotearoa perspective in the study that I did, experiences of staff working in children's blood and cancer centres. So this was a grounded theory study, so a qualitative study that used a framework of social constructionism, recognising that social approach that I've just talked about. It included staff from both tertiary children's cancer units in New Zealand. So we have one unit in the South Island, the Children's Haematology and Oncology Centre in Christchurch, and we have a unit here in Auckland, the Starship Blood and Cancer Centre. What was unique about the study was it also included everybody that worked in the unit, regardless of their profession, their discipline or their role. So it included nursing staff, allied health, medical staff, administration staff, cleaning staff, support staff. Anybody that worked in the unit was invited to participate. I think including all staff reflects the way we work in paediatric oncology and in paediatric palliative care. And I subsequently learned the huge value in including everybody and in talking to everybody. The experiences of all the staff were very similar regardless of their role, their years of experience, their discipline, or their job in the unit. And the things that they felt strengthened them to do their job were also the same. There were 30 staff in total that participated across a variety of those different disciplines and professions and across both units. So a good cross-section of staff included. And what I identified was that staff working in children's blood and cancer centres maintain their resilience by being a collective and being a work family. Hence the title, We Are All a Family. So the findings of the study have been published in the Journal of Paediatric Oncology Nursing, which you can have a look at if you'd like to read more. But being a work family means staff venture through a process of finding attachment through being new in the team, being supported and nurtured, and through social connections. They then, with the support of having a mentor, become part of the work family through being a team, sharing success and burden, and having core work family values. As a family, they're then able to develop an identity as individuals within that family, but also as a family group, and their identity as a family was defined by the ability to make a difference and the importance of being valued and appreciated for what they do. I'm going to walk through some of those findings in a bit more detail now. So the work family, what does it look like? Well, being new was recognised as a period of greatest vulnerability. And I certainly can relate to that. I vividly remember my first day working as a staff nurse in children's oncology. When you're new, you're in survival mode. It's a foreign environment, a foreign world. It's similar to being a newborn baby in many ways, a time of transition and adjustment to being out in the big wide world. Often the first contact and attachment is formed with your manager, usually the nurse manager or clinical director here in New Zealand. And some staff refer to their manager as a work mum or a work parent. Staff that felt well attached to the unit and their work tended to see their manager as someone who was nurturing and caring and someone who had their back, much like a parental figure would operate. They also really appreciated the boundaries that were put in place from that parental figure and role as well. So it wasn't all about the nice stuff and nurturing and caring. It was about being a leader and a manager and putting those boundaries in place as well. Concurrent to the attachment being formed with their work parent or their manager, there was also an attachment being formed with a mentor. And having a mentor was seen as a really important part of attaching to the work family. That mentor was seen as being like an auntie or an uncle figure, someone that you could turn to in both a crisis, but also on a day-to-day basis to support you in finding your place within that work family. That mentor might be someone that was identified by the manager, but it also sometimes was someone that was informally identified by the health professional or the staff member themselves. Once an attachment was formed with a mentor, staff were then able to attach to those in their immediate team. And staff tended to attach to those most like them to start with. So a young nurse starting out in the unit tended to attach to the other young nurses and new nurses in the unit. Then they grew that connection to the wider nursing team, and they were seen as their siblings. And it was the same if you were in a different profession. So medical staff tended to attach to other medical staff before attaching to the wider multidisciplinary team, who were then seen as cousins. And once those attachments were formed, social connections were able to be developed throughout the whole team collectively. So social connectedness is an essential component in maintaining the work family. With resilience, particularly within the literature around older adults, but also within the adolescent population as well, looking at the correlation between meaningful relationships and resilience. What was really interesting is staff were really clear that it was important that connections were established and maintained through interactions both in the clinical environment, but also outside of the clinical environment and outside of work. So sometimes that was about simply sitting down and having lunch with someone in the tea room, having a cup of coffee together, or it might have been going for a walk up after work together, or having an after work meal as a team collectively. But it was really important that the social connections weren't just limited to the clinical environment in the unit. So what about when those connections are broken or they don't exist? And I meant to say earlier, but 2 of the staff that were interviewed had actually left the unit prior to participating, and both had left 2 or 3 years before they participated in the study. And we know that social connections can be broken or don't exist for a variety of reasons. Social connections can wear away because of personal or family situation changing, or in one situation, the unit rapidly growing and the person being lost in the size of the unit. You'll see from this quote from a participant that had left the unit prior to participating that they were really, really torn. Though between wanting to stay and enjoying the work, but really carrying the emotional and physical burden alone. So those who identified as not being socially connected to their colleagues tended to carry that burden alone, and felt much, much more traumatised by the work. And this had actually led to the staff member deciding to leave. So you might be thinking at this point, well, what makes a family rather than just being a team? We know that a family isn't just about blood connections. It's not about sharing a last name. It's about so much more than that. It's something that's defined by commitment and care for others, and about core values, which nearly all participants in the study talked about. They talked about respect, trust, loyalty, honesty, mutual support and guidance, really caring for each other. But it doesn't necessarily mean that everyone will be happy, get along every day, and things are going to be perfect. And just like our own families that we belong to, we know there will be days when there is a level of dysfunction. And I couldn't put it more perfectly than this participant did. If we functioned perfectly and everyone got along really well all the time, we would just be a team. But the fact there is a level of dysfunction, sometimes we don't agree, and sometimes it is a crazy place. That's what makes us a family. And really, I think ultimately what being a family is about is that when the chips are really down and there is tough stuff happening, families pull together and support each other. Oops. So what does the work family offer? And what does this theory provide teams? I think the analogy of a family is something that is easy to understand and something that we all can comprehend.
Did we just lose Emma on the screen?
I think she has reconnected back.
Yeah, okay. Welcome back, Gemma.
Thank you, sorry.
No worries.
Where did I get to? So hopefully this is where I got to. We'll see how we go. So what
kind of work family provide?
Right, cool, thanks. So I think the analogy of a family is something that's easy to understand. It's something we can all comprehend, although we all have very different experiences of being a part of a family. And I think that's important to acknowledge. It provides a sense of belonging, a sense of being valued, and highlights the importance of caring for ourselves, but also importantly, caring for each other. There's a sense of commitment to the common goal and to our colleagues to work together to achieve that common goal. And in this case, it was quality care for children and families within these units. I think this concept and theory does provide the ability to share the burdens and to celebrate the successes together. And I'm not just talking the big burdens, the really tough stuff, but the little struggles along the way. And the same with success, not just the big wins, but celebrating the little wins that we have on a daily basis. They're important too. I also think that one of the most powerful things with this theory is there's an acknowledgement that we are all in this together. And by all, I mean everybody that works in a unit. So acknowledging our colleagues that have traditionally not been acknowledged in any interventions in hospitals or within research. So cleaning staff, administration staff, but realising that we are all in this together, and that we need to look after everybody regardless of your role. So on a practical level, I think one of the most powerful things that someone said to me at the completion of this study was a senior nurse that had worked in the unit for a long time. And she said, Gemma, we've had lots of studies that have tried to explain lots of different ways that we should look after ourselves and what we should do. But finally, I feel like there's a theory that describes who we are and how we operate and how we work. And I think for some people, that's a comfort in knowing they're not alone. And it's actually okay to find that this is tough and to have difficulties in this work. in putting this into practice, I think it's strategies and interventions that can maintain social connectedness. And that's going to be something different in every unit, depending on the unit's culture and what works for that team. And creating an environment that people can openly talk about the burden and challenges, particularly senior staff sharing with their junior colleagues their challenges that they've experienced, and really thinking about that notion that it is okay to not be okay. We're not all pillars of strength all the time, and we're going to have moments that we struggle. So really thinking about that permission to fail, permission to be a human being. So what are some of the strategies and interventions that teams came up with? The oncology teams, food was really, really important. One of the units had a baking day, that they had a roster and people brought in a cake or muffins, and there was lots of discussion as to who could bake the best muffins or the best cake, and sharing of recipes, which really encouraged people coming together. One team said the most helpful thing for them was actually a shared lunch, the ability to come together and share food. Twinkles, which are little sort of post-it notes, I guess, that get put on the wall and acknowledge someone's done a good job. So focusing on the things people do well, rather than living in a world of constructive criticism, but often we focus on the negative. Learning something new together. I'm part of a team in the School of Nursing, and we're learning te reo Māori, waiata, traditional Māori waiata, and karakia together. And I think that's a way of really connecting and learning from each other in an environment. I've put up the top there karakia, and I certainly know a primary health care team in New Zealand that heard about this theory and sat down and said, what can we do to put this theory into practice in our environment? So they now start the day with karakia, which is a Māori blessing or prayer. And it's an opportunity that they come together, they check in with each other at the beginning of the day. Sometimes that's not about sharing details, but just saying, I'm having a tough day, I've got lots going on at home. I've got lots happening for me. So just acknowledging what else is going on for people. I think importantly, having spaces in our hospitals for staff to connect. And I know that's certainly a challenge in New Zealand hospitals. Often we focus on patient spaces, but really considering how we look after staff and the physical environment we work in. One thing that came up in our COVID world we live in is allowing time to socially connect at Zoom meetings rather than getting straight to business, having time to chat and check in and see how each other is doing. Having senior staff champions to champion the theory, really good aunts and uncles that can take new staff under their wings and support them to attach to the work family. And one team talked about the role of social media in encouraging social connection outside of work, but it did come with a few warnings, as social media often does come with. So in summary, before we get to discussion and questions, I think there is a real need to rethink how we approach staff wellbeing and resilience, and a need to shift the focus from the individual to really thinking about the collective and taking a social approach, thinking about the team as a whole. I think social connection is incredibly valuable, and we need to think of ways in which we can enable that both in the clinical setting, but give people an opportunity to connect outside of work as well. And I challenge you to really consider and think about your own work family and how you can have an impact on bringing your work family together and looking after each other. So just to finish before we move to discussion, me mahi tahi tātou mō te oranga o te katoa. This is a traditional Māori whakatauki, which means we should work together for the well-being of everyone. I think ultimately that's what this is about, is how do we work collectively to support each other as we care for children and families in our work.
Thank you, Gemma. Right. I think we were all quite absorbed in the presentation. I don't see or hear any questions that came up unless I missed any. So if you can just put your thoughts into words and put them on the chat so that we can address them in the next 10 to 15 minutes, if we could, on this particular topic and some of the, whether it's inspirations or reflections that came up as you listened to the talk. Does anybody want to ask any questions at this point? What you need to do is just unmute yourself and you can ask directly using your voice. If not, just type your question in the chat box and I will pick it up.
Hi, Gemma. My name is Heng. I'm a family medicine doctor in Malaysia. All right. So I really found it really interesting and it really resonated well with me, the idea of building a working family to actually support you to get through the working stress, right? I was just wondering, was it difficult to create that social connectedness or that working family relationship? I mean, like, what were the challenges that you faced when you tried to implement that in your working place?
Thanks. So I guess just to be clear, I didn't implement this model or theory at all. This was what I found in researching these staff. So those processes were already in place, and I think a lot of it has naturally and organically just happened. But I think it's how do you maintain that, particularly in times of stress and difficulty. And I think going through COVID lockdowns and the challenges that they face is a classic example. So thinking about how we can be creative and still socially connect without physically being able to connect with each other.
Yeah, because with the COVID lockdown and everything, even among healthcare professionals working in the hospital, we do have restrictions. There have been warnings not to have pantry meetings because when you're in the pantry and you're eating together, that's when your masks are off and you are in close contact with one another. But yeah, I really do believe that, having a good working relationship with people around you, and that you have team members that you can fall back on when you're feeling all stressed out, somebody that you can talk to about your whatever is stressing you out. It really helps a lot. Thanks.
Absolutely. Thank you.
I think Gemma really wanted to share all the rich findings that she got from her study. She didn't quite sort of spend a lot of time talking about her study design or the sample. So I was just wondering, maybe just to put the findings in context, in view of what Chong had just brought up, which means you actually went to this hospital that you were working in and sort of engaged all of the different types of staff in the oncology department. Could you kind of tell us a little bit, if you can, about the sample? That I think it's worth sort of having people appreciate that it was not all nurses you spoke to, but a whole sort of group of very diverse healthcare professionals, and I think allied health staff and cleaners, as far as I remember when I read your paper.
Absolutely. Gemma? So it was a grounded theory study, qualitative study, and there were 30 staff included, as I said, across all disciplines. Nursing were strongly represented because they're the biggest workforce in most units. So I think 46% were nursing staff. There are about 30% that were medical, which again reflects how the population's made up, but also representation from cleaners, allied health, which included place specialists, social workers, cultural support workers, pharmacists, administration staff and research staff. And initially I ran 3 focus groups, which had a range of people in them. So they weren't limited to profession or discipline. And the discussion in those was incredibly rich. And I think that was probably the moment I realised that there was huge value considering the social approach to this, and to realising that actually we need to think about how we can look at resilience on a team level. From those groups, I then went and did individual interviews and further explored some of the themes that were coming out of those focus groups and some of the codes and categories that came from those focus groups. And then towards the end of the study, I actually did 2 further focus groups with senior leaders, which weren't included in that initial 30 participants, to kind of co-construct the recommendations and findings realising that as a researcher going into these units, what I suggested actually needed to work for the unit. And so we did that together. I guess one of the interesting things was that the Auckland unit I had been a staff member in, I still work in frequently as a nurse specialist in children's palliative care. The Christchurch unit I have quite a lot to do with in my nurse specialist role, but don't know them as well. And so I was really working as an insider researcher in one unit and slightly removed in the other unit. And so that was an interesting experience as well. Yeah.
Thanks, Gemma. I'd like to pick up a point mentioned by Suzanne from Perth, Australia. She liked the slide with permission to fail, forgiveness, acceptance, trust, and love. I think what she wrote about spoke to, I believe, the values that exist in the team, or AKA the work family in this particular instance. And it probably resonates with many other people here. I think this is a question related to, I believe, also what you mentioned earlier about your sample. Wilma Stewart asked about how do you include casual staff who work regularly in an area but aren't really part of it. So I believe perhaps maybe the cleaners, the managers, or the secretarial staff in the oncology unit would be, you know, the group referred to. How do you include them as a work family?
I think it's a real challenge, but I think it's really thinking about that bigger collective group. And when you're on a shift, seeing everybody as the team, regardless of whether you work there a day a week or 4 days a week, but really being inclusive of everybody and looking out for each other. And so that's where I think things like baking days, sharing a cake over morning tea can be really helpful, because it's a way of drawing people in to connect together and be together. In terms of the actual study, there was no restriction on how often you worked to be included in the study. So some staff were only working sort of a day a week and others were full-time.
It's very interesting that you actually included them, and I think that was one of the novel things that your study kind of attempted to do, which is to include the perspectives of so many different types of people, rather than the ones who are deep, you know, providing the service or rendering the support. So I think there's a very interesting question coming from Agnes from Manila, which was a question I also wanted to ask myself. So she commented that it was a very nice concept about the work family, and she never thought of it before. It's a very practical approach that, you know, is very intuitive. And she always worked from a senior junior or mentor mentee approach when it comes to kind of bringing in somebody new. How can boundaries be maintained in a work family approach? So for me, I've often kind of wondered whether I should even tell, you know, my team members, oh, I lost 5 kg successfully, or I've got a new girlfriend, or something like that, you know. So how do you draw these boundaries between what's appropriate for work and what you keep to your, you know, your personal space, you know, in light of your study findings?
Yeah, so I guess some of that's a personal choice. I guess that's a personal choice as well as to how much people want to share, and nobody should be pushed to share more than they're comfortable with. But I think what people found was that they want to know about the human beings doing the work, not just the professional person. And I think from talking with some of the managers, they saw that as a mutually, you know, like a mutual relationship. So while, you know, I remember one of the managers saying, you know, I feel like I'm their work mum, but they're my children, my family at work, and I get as much support from them as they get from me. And so they did share things like what was happening with their children, what was happening at home, that they felt comfortable with. And I think that really showed staff that they were human, that they had lives outside of work as well. I think in that managee or employer-employee relationship, staff really felt that that work parent also had to have boundaries. just like a parent would parenting a child. And I thought that was really interesting, that it wasn't all about being nurturing and caring, but actually people found it helpful when there was boundaries that said, actually, no, we can't do that, or that's not going to work, or, you know, put things in place. And so I think as a manager, having those boundaries in place is really, really important. And I guess much like children, it's probably really reassuring for staff.
Now, thanks very much. I think that's really helpful to kind of to know. But I think we ought to continue to reflect on you know, how boundaries can continue to exist whilst you are embracing everybody else in your office as part of your family. And we have got two related questions, one from Marianne and the other one from Cindy, about then what happens if this work mom is very unhappy and, you know, with the work child or the work baby, particularly when problems arise in the work domain. How do we, you know, resolve that? And how do we introduce new members to the existing work family, particularly if this new member had kind of appointed a role that he or she plays rather than it was assigned? I hope you get that question. So it's about conflict management within this family, and it's about assuming a position within this family. So you are mum over time, but some people come in and said, oh, no, I'm the big sister.
Yeah. So I guess while I've made kind of generalizations of roles to shape it up in a family, roles change. And, you know, within, and I guess, you know, considering that in a tertiary children's hospital, work families also have cousins in other departments. And other departments that influence those relationships and makeup. And so that's an important thing to acknowledge as well. I think conflict's really, really difficult. And conflict's really difficult to manage in our own families. And I don't think there's a quick and easy answer, but I guess what I learned from the staff that I interviewed is that conflict's actually easier to manage when you've got really strong connections and relationships already in place, that you can be honest and upfront with each other. It's much more difficult when you don't have those relationships in place to start with. Yeah.
Totally agree with you. I suppose what the study findings had shown really is more about what had kind of been helpful in the past or in their experience. And I do remember having read that some of the people who were contributing findings actually had left the department. I can't remember how many of them, and it's brilliant that you were able to kind of have them also contribute to your study, because it would actually add another dimension to you know, your study findings. So I wonder if anybody wants to ask any question online live. I'm opening it up again in case, before I go to the next question on the web, which is around institutionalization of this approach. I think is in terms of, I suppose, putting it in action. Yeah, Elida, did you want to ask a question?
Yes, go ahead.
Hi, Elida is a colleague in HCA Hospice in Singapore.
Hi.
Yes. Gemma, thank you very much for the very insightful, and really, it's really very inspirational as well. And I do have one question. I wonder whether have you interviewed any of the staff with special needs, which means that, you know, staff who may have how do I use the word to be a bit more diplomatic? You know, staff.
Say it, Elida.
Say it how it is.
Colleagues who have who have special needs, like some spectrum of ASD, you know, who are more, or even for people who are more introvert, you know, because it will be very difficult for them to connect. And what was your experience like? Yeah, when you interviewed them.
So I guess that's one thing I did acknowledge in the study that may have been a bit of a limiting factor, is that probably the people that agreed and volunteered to come and talk with me in a focus group or an individual interview were the people that were more likely to find socially connecting much easier. And so I think that that is something that would be really good to explore in the future, using other methods of collecting data to find out what their experiences are. But it certainly wasn't something that staff highlighted in talking with them, that there were colleagues that that struggled to do that, I guess. Yeah, does that answer your question?
Thank you.
Hello.
Hi, Suraj.
Hello. I'm Suraj, medical doctor from National Cancer Control Program, Sri Lanka. Thank you, Gemma, for the inspiring lecture, because we get a lot of things for the practice, as well as a lot of things for our work culture, as well as a lot of things for our heart also. I think these things are very much needed to institutionalize in our setting, because these days in Sri Lanka, we are brainstorming to develop 5-year national strategic plan on childhood cancer. So we are contacting the different stakeholders, from medical doctors, nursing groups, social worker, administrators, the patient groups, the NGOs, like things. I want to know this work culture, the family culture, introducing family culture to the work norms is very much needed to as a measure of resilience. Do you have experience in introducing this to the institutionalizing these concepts? Because it will be helpful for other countries to incorporate to their individual institutional plans as well as national plans. So I want to get some feedback from you about that aspect. So that it may be a little bit beyond the research.
Yeah. So yeah. So I mean, I haven't particularly looked at evaluating it being implemented in other areas, but I am aware, as I said, of it being implemented in a primary care setting and in a tertiary education setting. And certainly I think how it's implemented is different in every unit depending on the culture and what works for that particular unit. But you know, as I said, one primary care team are starting the day with kara care, or traditional prayer, coming together to connect, checking in with each other. They've done things like arrange a monthly lunch outing for them all to come together, and kind of those regular team meeting opportunities that aren't necessarily about business and what needs to happen clinically, but are about looking out for each other and connecting.
Thank you. Thank you.
Thanks, Gemma. I think with that comment, I would like to bring today's meeting to a close, if that's okay. I'm so sorry that we may not be able to address all the other questions that are online. We will try to collect or pick up all of these open ones and then reply to you individually. I just want to thank Gemma, sorry, again for volunteering to not volunteer, I arrowed her. She was invited to share with us this work that she has done, because I think when I first read about it, early this year, I was really picked, by the topic that she has chosen. As I've said right at the beginning, this is something that is close to my heart. And I dare say it's close to everybody's heart, because all of us who are working in this line actually come with a lot of passion. But sometimes when you join a team and it doesn't quite work out, or it was okay in the beginning and then just turned kind of sour or worse, bitter sometime along the way, you start to wonder what has gone wrong, what hasn't been done right. And I think this framework of having a work family is a good way to start. Although we must acknowledge, just like how Suraj has brought up, a family is something which is unique to a certain team, to a certain context, to a certain culture, and it takes time to actually build a family. When a baby is born, you don't automatically have a family. There is a lot that needs to be, nurtured over time, to be safeguarded, to be built. So I think it's a good start that we can all start to think about how to build our own families where we are. And I particularly like Chandima's analogy. Actually, this community is one big family. So with that, I'd like to thank all the Aotearoa people who were online this afternoon for joining us. And again, thanks, Emma, for helping to stimulate this very lovely discussion here. Thank you very much for your attendance. I'm going to call this meeting to a close now. Thank you. Enjoy the rest of your week.
Thank
Thank you so much.
Thank you all.
Thank you, Emma.
Thank you.
Bye-bye.
Thanks, Gemma. Bye.
Bye.
Bye-bye.